So good afternoon. It gives me great pleasure to welcome our dear friend, Dr. Ali Jawad. Ali needs no introduction. He's a member of our society and has been a great supporter for our meeting since it was launched 10 years ago. So without further ado, Ali is a consultant traumatologist at the Royal London Hospital, Barts Health Trust in London. He's a professor of Rheumatology, William Harvey Research Institute, also at the Barts and London School of Medicine. He was a Fitzpatrick Lecturer for 2020. Is a member of the think tank committee on global health for the G20 Summit 2020. He's originally from Baghdad. He has published widely 3 books, chapters in several books, and more than 267 articles in Learned Journal. He won several research grants investigating the role of cytokines on bone in RA and runs a metabolic bone service. He is MRCP UK, a clinical examiner and external examiner for the Imperial College London, Singapore, and Sultan Qaboos University College of Medicine. He was global vice president of the Royal College of Physicians in London, and he was the director of medical and dental education and Barts Health Trust, Royal College of Physicians Medical Director, Global Medical Director, and the Associate International Director for the Middle East and North Africa. Dr. Jawad will talk to us today about a very challenging topic about myositis, inflammatory myositis. As you know, this is a very challenging for us as a clinician. Whenever we face a case of myositis, we are always at the dilemma: is this inflammatory, is this genetic, is this metabolic, drug-induced? So it's a very challenging topic, and Dr. Jawad will enlighten us about this important topic in our practice. Dr. Jawad, the floor is yours.
I am going to talk today about the classification and diagnosis of Dermato and Polymyositis, in other words, the idiopathic inflammatory myopathies. Now, the outline of this talk is as follows. I'm going first to mention the Bowen and Peter classification, followed by the 2017 EULAR and ACR classification criteria for adult and juvenile idiopathic inflammatory myopathies and their major subgroups. And at the end, I will be mentioning the various phenotypes of the idiopathic inflammatory myopathies. But first of all, we need to mention the SARS coronavirus 2 and its effect on muscle. Myalgia and fatigue are very common, but evidence for viral myositis is lacking. In Wuhan, 11% of patients had evidence of muscle injury with elevated creatinine kinase of more than 200 and/or myalgia. There have been only 2 case reports of rhabdomyolysis associated with a CK of more than 12,000. Now, the idiopathic inflammatory myositis group is characterized by essentially inflammation of skeletal muscles. And back in 1975, Bowen and Peter proposed the following division: primary idiopathic polymyositis and dermatomyositis, and dermato and polymyositis associated with neoplasia and the childhood variety. And these were the diagnostic criteria. Symmetrical proximal muscle weakness, elevation of skeletal muscle enzymes, characteristic myopathic EMG changes, and a positive muscle biopsy. To diagnose polymyositis, you need 3 out of the first 4, but for dermatomyositis, you need the characteristic dermal signs plus the 3 of the first 4 criteria. Now, the myopathic changes are quite characteristic, and I've listed them in this slide. But however, this is not diagnostic and is generally present in only 40% of patients with either dermato or polymyositis, while 10% of these patients have normal EMG results. The muscle biopsy in polymyositis is mainly characterized by the CD8 positive lymphocytes, while in dermatomyositis there are CD4 T lymphocytes, B cells, and macrophages. And this is a biopsy from a patient with dermatomyositis, that is chronic. You could see the fibrosis in the perivascular area, with a lot of atrophy of the muscles, with infiltration by not only but by lymphocytes and macrophages. While the inclusion body myositis, the histology is very similar to polymyositis, but they also have these lined vacuoles which are filled with deposits of beta amyloid and ubiquitin. However, there are challenges. Now, the changes in biopsy suggest 3 different separate conditions. The reality is there is a lot of variation in pathology, and sometimes you have a patient who has polymyositis but has the pathology of dermatomyositis, or you could see a patient who have the dermal manifestations, yet the histology is that of polymyositis. So that has proved challenging over the years. An MRI scan is very helpful because you could see, especially in the fat suppressed image, you could see the inflammation and the edema in the muscles. This was a child with active dermatomyositis. So the limitation of the Bowen and Peter criteria is they do not clearly specify how to exclude other forms of myopathies. They also misclassify inclusion body myositis as a polymyositis, while the reality, as one of the leading neurologists in London said, that really IBM is Alzheimer of the muscle, and essentially it's a degenerative condition. They also misclassify muscular dystrophies as myositis, and therefore the criteria are not really defined explicitly. And this led to the EULAR and ACR to recommend a new classification criteria both for adult and juvenile idiopathic inflammatory myopathies and their major subgroups. And essentially they place a lot of emphasis on the pathognomonic skin rashes, and they chose the heliotrope rash, the Gottrin's papules, and the Gottrin's sign are accurately classified in the EULAR and the ACR classification without needing to have a muscle biopsy. For patients without these dermal manifestations, a muscle biopsy is recommended, while those who have dermopathic features without muscle involvement, they recommend a skin biopsy. They generally, they're a little bit complicated when you read the paper. However, I mean, in essence, each probability has a unique sensitivity and specificity, and it's given a number. So they found that the probability of 55 to 60%, that is the total aggregate score, which is more than 5.5 and less than 5.7, not including muscle biopsy. And for those with muscle biopsy, then the aggregate score has to be more than 6.7 and below 7.6. The recommended cutoff needed for classifying a patient as idiopathic inflammatory myositis is more than 55%. And you could see that, for example, they listed the various variables, and without muscle biopsy, they're given these numbers, and with muscle biopsy, these are the score points. And you can see, obviously, age of onset is important because to classify the condition as juvenile or otherwise. You can see, interesting, in the muscle weakness, the one that is terribly important is the weakness of the neck flexors compared to the neck extensor. That seems to score much higher than weakness of the proximal muscle. So bear bear that in mind. And these are the three pathognomonic or characteristic rashes in dermatomyositis. The heliotrope rash, and you can see it scores very highly at 3.1 without a muscle biopsy, and 3.2 with a muscle biopsy. And the Gottrin sign, which is essentially a macule, which is not palpable. If the Gottrin sign, if the erythema is not palpable, then it's called a sign. If it's palpable, as in this case, then it would be a papule. And essentially, the Gottrin sign scores much higher than even the muscle weakness. You can see 3.3 and 3.7 for Gottrin sign. Although there are other rashes of dermatomyositis, but they are not entered in the scoring. For example, this is a patient with a malar-like rash, and this is the classical V neck rash, and this is the shawl sign in dermatomyositis, and this is the Gottrin's erythema and the holster sign, as if you're holding your gun in its holster on the side, just below the trochanteric area. And obviously the cuticular changes with the periangular erythema, and you could see the dilatation of the blood vessels. So these are not classified, but they are important to look for. Mechanic hands, essentially there's a lot of fissuring with hyperkeratotic papules and painful fissures along the sides of the fingers and the palm. Generally, you could also see telangiectasia and splinter hemorrhages, but characteristically, the rash is over the radial side of the index fingers. This is especially characteristic for the anti-synthetase syndrome. And you could see, for example, the autoantibodies is scored very highly. The Jo1 antibodies 3.9 and 3.8. That's without a muscle biopsy, and that with muscle biopsy, while the others do not score as much apart really from the biopsy. So you could say if a patient has positive Jo1 antibodies and has the heliotrope rash and the Gottrin sign or Gottrin papules, then the diagnosis of dermatomyositis is made. So these are the recommendations. Definite IAM corresponds to a probability of more than 90%, so a total aggregate of 7.5 without muscle biopsy and 8.7 with a muscle biopsy, because obviously the score for the muscle biopsy is added to the rest of the score. And if it's possible IAM, then the score is generally between 5.3, above 5.3 without a biopsy and above 6.5 with biopsy. And although the descriptive terms possible, probable are used, they are not important as the definite and the possible. And so just in summary, if the age of onset is under 18, if under 18 and the patient has heliotrope rash and the Gottrin sign and papules, then that's juvenile dermatomyositis. If the absence of the rashes, then with muscle weakness, then they will have juvenile myositis. If they are over 18 with the rashes plus the muscle weakness, then it's dermatomyositis. Without muscle weakness, then it is amyopathic dermatomyositis. If there are no rashes, then it depends upon other features and you need a muscle biopsy, as it could be IBM or it could be immune-mediated necrotizing myopathy. Now, the various phenotypes are also important. The anti-synthetase syndrome, the immune-mediated necrotizing myopathy, the cancer-associated variety, and the MDA5 associated dermatomyositis, which is very, very important to recognize early. Less important is the myositis associated with calcinosis. Now, the anti-synthetase syndrome phenotype, typically these patients have, as I said, mechanic hands, they have Raynaud's, they have fever, they have arthritis, and interstitial lung disease. However, there are at least two atypical phenotypes. Sometimes you see the pulmonary disease without muscle involvement, and sometimes you see myositis without any of the other features. Although there are several anti-aminoacyl RNA synthetase antibodies, Jawad is the most common, and the PL7 and PL12 are associated with severe interstitial lung disease. Now, the statin-induced myopathy is important to recognize. More than 10% of patients treated with statin will have some form of muscle problem, either muscle pain, cramping, tenderness, weakness, and it could be in the chest muscles, in the thigh muscles, in the biceps, the abdomen, and the CPK could be either normal or more than 10 times the upper limit of normal. A small number may develop immune-mediated necrotizing myopathy, and that is usually associated with the HMG-CoA reductase antibodies, and these patients may require vigorous immunosuppressive therapy. Now, the immune-mediated necrotizing myopathy has been, as I reported, with the statin therapy, and the statins are HMG-CoA reductase inhibitors, and they are very rare, 2 to 3 patients out of every 100,000 patients treated with a statin, and the onset may vary. It could come very soon after initiation of treatment, or it could come really many months after starting treatment, and sometimes the signs could be just muscle pain or difficulty in rising from a chair, or climbing stairs, or lifting heavy objects. The weakness usually persists or worsens if the therapy is not discontinued. If it is not discontinued, and in most cases the patients have generally mild to moderate symptoms. However, severe changes could have been reported. So most of the patients would have some form of mild joint pain, or you could see erythematous rashes. The diagnosis is based on the following: symmetrical muscle weakness, CK more than 2000, the antibodies, EMG, muscle edema on MRI scan, and the muscle biopsy is very, very characteristic. It is essentially phagocytosis of myocytes by macrophages. You could see, for example, you can see the macrophages here causing myophagocytosis. And if you look at the special stain, this is CD68, which is for macrophages. You can see it's full of macrophages, and this is for CD8, the cytotoxic T cell. You can see there aren't many lymphocytes, and this is for CD20 for B cells. You can see there the paucity of these cells, while macrophages is the main feature. Now, some patients, when you detect these antibodies in someone who is taking a statin, then you should immediately recognize that there is an autoimmune process ongoing. They have not been detected in statin-treated patients who do not have muscle disease. So essentially, when they are present, there is muscle disease. If they are absent, there is no muscle disease. But however, there is a small number of patients who are younger and have a very resistant myopathy to therapy. These patients have never been prescribed statins, and they have positive anti-HMG-CoA reductase antibodies. These are usually patients who eat red yeast rice. Now, red yeast rice is full of statins, and they have people who eat red yeast rice regularly. They tend to have a lower lipid profile, but they are susceptible to all the muscle complaints that patients with statin have. Now, the MDA5 associated dermatomyositis phenotype, MDA stands for melanoma differentiation associated gene 5. Now, these patients have very characteristic skin manifestations, and these patients have very little weakness in the muscle. So they tend to present more for dermatologists or respiratory physicians because they have lung shortness of breath. They present because the lung is involved. And generally, in addition to the Godwin signs and papules, they develop ulcerations, sometimes in the palps, around the nail folds, for example, here. So generally, when you see dermal manifestation of dermatomyositis associated with ulceration, then you should immediately think of an MDA5 associated dermatomyositis. And they can also have oral ulcers, alopecia, diffuse alopecia, and joint symptoms, but they have a low incidence of myositis. But they have a very high risk of interstitial lung disease, which could be rapidly progressive with high mortality. The two patients that I have seen have both died in spite of recognizing the condition very promptly. So it is really important to recognize the cutaneous manifestation early and administer therapy as soon as possible. Now, the myositis associated with calcinosis are associated with anti-NXP2 antibodies. The NXP2 antibodies, these are in a way important because these patients will develop calcinosis even if these patients are treated early. This is one of my patients who is a 60-year-old Afro-Caribbean woman who had amyopathic dermatomyositis, hardly any muscle weakness. And you could see the calcification occurred in the subcutaneous tissue rather than in the muscle, because she has no muscle involvement. She did have, in fact, severe generalized erythroderma when she presented. And so when it healed, eventually the calcification developed. And it's not related to delay in diagnosis and treatment. This is another patient, a 31 Bangladeshi woman who had anti-synthetase syndrome. And she was treated with cyclophosphamide and now currently on methotrexate and prednisolone. She developed the calcification within the muscle. You can see this is a tumoral calcification in contrast with the calcification here, which is in the subcutaneous tissue. Now, cancer-associated myositis, we know that nearly a third of patients with dermatomyositis can have malignancy, and sometimes the malignancy is covered after the diagnosis of dermatomyositis, usually within the first year. Ovarian cancer is the commonest, but lung, stomach, breast cancers, and non-Hodgkin's lymphoma have all been described. And typically, the antibodies that are associated with adult dermatomyositis and cancer are TIF1 gamma and NXP2 and anti-SAE antibodies. However, the anti-TIF antibody, it's common in juvenile dermatomyositis, is not associated with cancer in juveniles. It's only in adults. And the patients with anti-TIF antibodies, they have very severe cutaneous manifestations. And it's really important. Now, there is the small anti-SAE antibodies, the anti-small ubiquitin-like modifier activating enzyme antibodies. These patients usually develop severe erythrodermic rash, very extensive rash. And when they get myositis, it's usually severe, and typically they have severe dysphagia. So if someone presents to you with an extensive rash, plus having difficulty swallowing, then you should think of anti-SAE phenotype of dermatomyositis. Two other antibodies, the SRP or the signal recognition particle antibodies, if they are present, the outcome is generally poor, while those who have anti-MI2 antibodies, the outcome is usually good. Now, to summarize, patients with paradigmatic skin rashes, the heliotrope rash, Gottfried signs, and Gottfried papules, whether they have juvenile dermatomyositis or adult dermatomyositis, are accurately classified with the new EULAR ACR classification criteria without including muscle biopsy data. Those who have the dermal manifestations but without muscle involvement, a skin biopsy is needed, while those without the dermal manifestations and have muscle weakness, a muscle biopsy is indicated. It's also important to identify other clinical phenotypes, especially the MDA5 dermatomyositis early, as the outcome in these cases may be very poor indeed. And thank you very much.